Hi, good morning, everyone. This is again Mr. Reyes with Careers Unlimited. We're going to be discussing Chapter 15 in the Patient Care Technology course. This chapter is very, very important because it really opens your eyes to any perspective of patient care. Through most of your patient care courses, you have learned a lot about personal care skills, nursing skills, and so on. Today, we're going to be learning about other parts of the care that also involve your intervention because when we administer medications, we expect certain side effects, and today you will see be part of it because you will understand what patients will be receiving in their care and what side effects are expected versus those that are unexpected. Good morning.
Good morning.
Are you on the road?
Yes, I'm apenas voy a salir de la casa.
Okay. Oh, so today's chapter 15 about medications, and you're going to be learning some of the things that we started on yesterday. Yesterday we talked general ideas about medications. You learned about the rights of medication administration, right? It was the right dosage, the right patient, the right time, the right frequency, and so on. So that is very, very fundamental. You have to make sure that you practice that all the time. Many times you'll be find yourself being in a hurry and skipping steps and so on, and that really opens up room for error for medication errors. So it's really important that you stick to those at least in the not only the beginning but throughout your career as you get into the nursing career. So the right documentation, the right route, the right time, the right patient, the right dosage. Those are the very basic fundamental things that you have to practice every single time we administer medication. So when we train in nursing for in this section in pharmacology, we go out there to the hospitals and we're given an assignment, and usually the clinical instructor will give us an assignment like very simple patient. Also depending on the student's I guess abilities. If we see a student that's like very kind of fearful or tends to make mistakes or doesn't prepare well, when before we administer one medication, we have to present to the instructor everything, not just about the medication, but about the patient. So we have to learn about the patient, all the medical problems, and then we're given the duty to administer a medication under the supervision of the instructor. But we have to tell them what it is, what it's for, the intended treatment, which is the therapeutic effect, and then of course the side effects. What possible side effects can this medication have on the patient? So once you do one or two medications and so on, it becomes a lot easier, But this is part of the care, and as a patient care technician, when you work in a facility, and I ask you to, if it's within your scope, some facilities will allow you to administer medications. If it's within your scope, then you're able to administer the medications safely. Again, safety is the name of the game here. Everything we do is in the name of safety. Did you hear everything else I said before?
Mande, sir?
Did you hear what I said earlier, right now, when I was talking?
Yes. Más que
Okay.
se quiebra como, no sé si sea mi conexión o sea usted, como que you're talking y se quiebra la voz.
Can you hear me well
Yes.
right now? Okay.
Yes.
It's because I connected the microphone and I think it was off or something, but it's back on. So
Okay.
administering medications is one of the procedures that you have to learn how to do. Okay, so we have to go through the 5 rights. We have to get a medication record and all that. There's, I think I mentioned it, there is a medication aid training. Those people usually get about, I think, I want to say $12, $13 an hour, something like that. they do get a lot of hours. They work usually from 7 in the morning to about 8 p.m., so 12, 13 hours a day. But they only work about 3 days a week. 3 days, and then they're off for 2 days, and then they come back for 2 days. They're off 1 day, and then 2 more days, and so on. So they get their hours. Recently, there's been an increase in demand of medication aids. Not sure why, but there is a procedure like that. Applying patches, transdermal patches, applying eye drops, applying ear drops, to kids especially. It's one of the procedures that are in the book. It's very, very simple procedures. Now, of course, applying a suppository, which of course we can't do here, but we can do it with a mannequin. But anyhow, that was yesterday, okay? So those basic rights was the main thing you should take from chapter 14. Now in chapter 15, we discussed common medications. The most common ones that you're probably ever going to see. We'll talk a little bit about them today. So, learning objective number 1, what are the 2 main types of pain medications and safety precautions related to the use? So as far as pain is concerned, we have 2 main types. One are non-prescription medications, like the ones you buy, over the counter, or they're called over-the-counter medications. These are used for chronic pains most of the time, and I'll go into the different categories in a bit. And then you have your prescribed medications, which are usually used for acute pain or serious severe pain, such as post-operative pain, or just sudden onset of pain, and you go to the emergency room and they'll give you either an injection or IV medication used to manage the pain. So that you can have it for acute or chronic pain. There's medications used to treat pain. They're often called analgesics. Analgesics is a Greek word that means pain. Okay, A is without, and analgesia means sense of pain. So let's start with the narcotic analgesics now. These there's a lot of different narcotic medications that we use, and but a lot of them have the main component. Most of the narcotic medications are made from some of the opium, the plant, the one that's illegal drugs, like for people that said cocaine. A lot of the medications are composed from that same plant, but of course they're legal. And a lot of people that get narcotic medications will develop a habit. They're habit forming. They're going to get used to it very quickly. And when they try to get off of it, it becomes a challenge because they start to experience withdrawal symptoms. Okay, but we'll go into those in a minute. So one of the main kinds of medications that you can buy over the counter are called NSAIDs, NSAID, non-steroidal anti-inflammatory medications. These are, you have a bunch of different kinds. You have ibuprofen, which is Aleve. You have acetaminophen, which people know it as Tylenol, and naproxen. I don't remember the brand name for that, but there's naproxen. And there's several others that are out there, even aspirin, which is called acetylsalicylic acid, ASA. Those are all types of pain relievers, right? They call it NSAIDs. They fall under that category. They're non-steroidal anti-inflammatories. Why are they called non-steroidal? Because there are some medications that are considered steroid medications, which are body forms also. But these steroid medications have a lot of other side effects, and they require a prescription because of all the adverse side effects that come with it. So NSAIDs are used very commonly to treat mild to moderate pain. It could be for acute pain, which is already going away, or for chronic pains, like mainly for older people that have aches and pains, joint pains, and so on. Right. So narcotic analgesics are used to treat severe acute pain, not so much for chronic pain. Now there are some people that have chronic pains like neuralgias, or what's the name of the nerve, sciatic pain nerves, or even people that suffer from phantom pains. Phantom pains are those pains that for people that experience amputations or loss of a limb, and they feel pain at the site that where they used to have the limb. Phantom pain is real, and it should be reported obviously to the providers, right, to their doctors or whatever. Okay. Now, not every person that receives a narcotic is going to be receive the therapeutic effect, right? For example, we have to have the pain receptors in our body to be able to benefit from a medication. Some people can receive morphine, which is one of the stronger narcotic analgesics, and they will not have any benefit at all whatsoever. So what is it? What is it? How does it not work? Well, because these people do not have those pain receptors, right? So when you take a medication, your body absorbs it, and in the neurons or in the nerve endings, we must have these pain receptors that connect to the medication chemicals, right? And that way we can receive the benefit. If we don't have those pain receptors, then it doesn't work. It doesn't work as good as it should, anyways. All right. So again, remember, it's not just about taking the medications. They have to work by the person having those opioid receptors, which most of us have them, but there's a few people out there that don't. These narcotics have been used for many, many years. Okay, they're not new to us. They've been around for thousands of years. But of course, before they were just used as a plant in their natural form. Now they're processed and available to us, but primarily by prescription, at least here in the United States. The original narcotic analgesics were made from the seeds of the opium poppy plant, which is the same one that is used for some people that make cocaine. It is a narcotic analgesic. It falls under a category of, according to the Food and Drug Administration, these are the category, I think it's category 4, which are very controlled. Right now, as we speak, the country has a, what do they call it, opiate crisis. Opiate crisis meaning that people are overusing opiate medications. There's one called Vicodin. Vicodin is a very, very strong medication, and it has been overly prescribed by physicians, and patients were becoming very addicted. All right, and to the point where some patients were going doctor shopping because, you know, one doctor could only give them so much, and they went to another doctor and they started searching for more prescriptions. So it became a real problem for doctors and also as a nation. So now every prescription that doctor prescribes for their patients is monitored very closely by the state. So the pharmacy has to give the prescription, right? So every time they input medication into the system, it sends a red flag to the state. So the state says, they kind of look for trends. If you see that this doctor is prescribing medication like it's candy, then of course they're going to come down on that physician and ask for a reason or a report. So they're getting very very strict about narcotic drugs. Some of the more common narcotics that you're going to find are morphine, of course. Morphine can be administered many ways. In the hospital, we administer it IV or injected, but it also comes in pills. We have codeine, which is the most commonly prescribed, and it comes with Tylenol, a combination of Tylenol and codeine, and it comes in various strengths, 30 milligrams, 40 milligrams, with Tylenol added to it, and so on. There's oxycodone, which also probably one of the strongest medications. It comes in a pill, it comes in a patch, it comes in injectable medications as well. That's another one, and then of course hydrocodone. Hydrocodone is Vicodin. It's a generic name for Vicodin, and fentanyl. Fentanyl is one of the medications I wanted to tell you about yesterday. It comes in a patch. It's administered transdermally. Right now, there's a lot of incidents of abuse of fentanyl. There's illegal forms of fentanyl that are out there on the street. They're being prescribed. I believe they say that it's coming from China, and people are buying it. However, they have no way of telling if this is a pure form of medication or it's been tampered with. And some people they add other components to it and they sell it in a little bag or things like that, and people buy it and they're overdosing. because of this. Fentanyl is, we use it more commonly for patients that are in hospice, that are actively dying and they're in pain. Well, the doctor prescribes the medication and we apply it on the patient's skin, and it gives them a very slow dose of fentanyl medication, but it does relieve the pain, but there are some complications with it. For any narcotic that we give, we have to monitor the patient's respiratory rate. Anything less than 12 respirations per minute is a red flag. It's a sign that the person's respiratory system is being suppressed. Right? The pulse oximetry reading, if you check it on the patient's finger, it should be always over 90%, 92%. If you see that dropping again, that could also be a red flag. But remember that pulse oximeter, sometimes they're not very accurate, especially if the patient's hands are cold, they have bad circulation. Those little devices can be relied upon. So you have to look at the patient, their circulation. Are their lips turning a little bit blue? They get cyanotic. Are their fingernails, are they turning blue, or are they pink? When you press on it, do they blanch and do they come right back within 3 seconds? So we have to look at the patient, not just the pulse oximetry. Of course, measure their breathing, count their breathing for 1 minute. Another common side effect with narcotic analgesia is constipation. It's a big problem, especially in the elderly. One, because while they're always, a lot of them are very sedentary. They just sit around. They don't have very much activity. And along with decreasing oral intake of fluids, along with inactivity, along with decreased intake in fiber, and so on. So a lot of these patients end up constipated and very constipated to the point where they may need an enema, which is one of the things we discussed yesterday, or suppositories or something, or even digital disinfection, which is a very procedure we don't want to do. But if we need to help that person obtain relief from constipation, this is one of the ways. The person's appetite is decreased when a person is on narcotic analgesia. Usually they're very sedated, right, in the beginning. Now, some patients may develop resistance to it, not resistance, but habit. The body becomes used to it. And then later, the effect is not as good as it used to be. Their appetite decreases and so on. And again, they become very addicted to it, okay? Now, a person that is in hospice and he's dying and they have medication for pain to relieve their symptoms, that is not an addiction. That is not an addiction. When I worked in hospice a long time ago, a young man and a woman, and the female was diagnosed with liver cancer, and she was dying, and I had to go teach the family, or the husband in this case, how to administer narcotic. It's morphine, but it has a different name, right? Nobody likes to give morphine. They don't like that word, so they give it a different name. But there are little drops. They come in drops in liquid, and we would administer it sublingual. So we instructed the patient on how to administer. But we went and I saw the patient, and she was always in pain. She was in pain, and I'm asking the husband, "Are you not giving her the medication?" He says, "Well, no, because I don't want her to get addicted." And I just sighed and was like, "Well, would you want to see her in pain, or do you want her to have relief?" And then he understood, well, addiction is not an issue right now. The person requires medication for pain management. It's not because they're addicted to it. We have to make sure that we monitor the patients, right, overall, not just the machine, the oximetry, but the respiratory rate is going to be number one. If you see them declining in the respiratory, obviously that's a problem. Some of these medications are also given through a machine after you have a serious procedure done, like abdominal surgery. Everything is swollen and very painful. Some of these patients actually get connected to a machine called a PCA, a patient-controlled analgesic, and we connected. And I didn't like these machines, but they have a purpose. Especially when we had patients that we knew they were had drug-seeking behaviors, we would connect into the machines, and they could press a button. And every time they had pain, they would press a button. and the machine would give them a dose or not give them a dose. Okay, so it kind of tricked their minds. So anyways, it was programmed to only give a certain amount of medication every time they pressed or every so often, but the patient didn't know. But the point was to be able to help themselves control their own pain. Okay, some of these patients had to be reminded to use it. Some would not use it. They would just want to take the pain, which is not a good thing. Pain is the fifth vital sign. It affects all your body, including healing. So we wanted to make sure that these patients were using the machine as instructed. So when you're caring for a person who's getting narcotic analgesics, again, monitor their respiratory rate closely, okay, and report any signs or symptoms like the breath less than 10, the decreased O2 sat, any nausea, vomiting, constipation, and so on. All right, let's move on to the non-narcotic medications. Observations to report for non-narcotics like the NSAIDs, non-steroidal anti-inflammatory drugs like Tylenol, ibuprofen, and so on. Tylenol has a high risk of causing liver damage. When people overuse it, I don't think you should take more than 2 grams per day. Your liver can actually start to suffer, right? It can get swollen, it can get irritated, and your liver enzymes will be elevated and so on. So report if they start complaining of stomach pain. Why your stomach? Because when you take a lot of NSAIDs, it creates a lot more acid in your stomach. Okay, so your stomach will be bloated and they complain of abdominal pain. Or they may start to have developing ulcers in their stomach, right? The small lining inside the stomach, it gets eroded, right? Because of the excess acid. Then they get a little ulcer. Then they start bleeding from the ulcer. Then the person may start vomiting blood or may start having tarry stools, black tarry stools. We call them melena. It's a medical term for black tarry stools. So if you ever see this kind of problem, you need to make sure that you report that. It's pretty much considered an emergency, right? Vomiting blood or having black tarry stools or bruising easily. A lot of times you kind of just like brush that off because a lot of the older people bruise very easy. They bruise very easily. They bump into anything. They're on aspirin. They're on anticoagulant medications and so on. And it's a common problem, even if they're not taking NSAIDs. But a lot of these older folks are. So non-narcotic analgesics are used to treat mild to moderate pain. And we measure pain obviously using the numeric scale or even the face scale. If they don't understand, we use the face scale, or sometimes we use other scales for people that don't understand. In addition to non-narcotic analgesics to reduce inflammation, they also lower the fever. We use them for that. Every medication works differently. So if a patient does not get relief with Tylenol or acetaminophen, they may get relief from ibuprofen because it works differently. All right. Now, we understand that it has a benefit, that it does work. How exactly it works, it's still not quite understood. Even in this time, in this year, we still don't know for sure how exactly these medications work. So please observe the patients. A lot of these patients have this problem. Now, there's other medications that are prescribed. These are prescribed and they're called corticosteroids. Corticosteroids are hormones in our body. They're chemicals that also help us to relieve pain. Okay, we have natural hormones that help us to do this. They're called anti-inflammatory. So your body produces these, but they're also produced synthetically, right? By chemicals. I guess science has created chemicals that are very similar, and they have the same effect, and they're very, very effective. These corticosteroids are very effective because they work almost exactly like the ones your own body makes. So they mimic or they copy the effect of glucocorticoids on the body. They suppress the immune system and reduce inflammation. So if you have, let's say, rheumatoid arthritis, if you recall, is an autoimmune disorder. So when your body attacks itself, it causes an inflammatory response, meaning there's going to be increased blood flow to a certain part of your body, either it be your joints or any other part of your body that is being attacked by itself. Corticosteroids will suppress that response, okay, and reduce the inflammation, especially more visibly if you have an arthritic person. If they have rheumatoid arthritis and you look at their joints, they're red, they're swollen, they're painful, when we give them a medication such as a corticosteroid, it reduces that response, thereby reducing inflammation and as a result, reducing pain. So that is what corticosteroids do as a benefit. Now, what are the side effects? The side effects can be a lot, okay, including the gastric problems. Okay, corticosteroids increase the amount of acid in your stomach by a lot. They suppress the immune system. When your immune system is suppressed, obviously they can catch infections from other people more easily. Their skin becomes thin and bruises easily. Their glucose levels, their blood glucose levels increase a lot, especially if they're already diabetic. We have to be monitoring their blood sugars. Now, these corticosteroids are available in oral tablet or IV medication or injection or through through IV infusion. A lot of these patients go for IV infusions in different parts, to their rheumatologist, a doctor who specializes in autoimmune disorders, and they get these infusions and they get a lot of benefit from it. Now, these are very expensive. They also get injections. Some people get injections directly into their joints, which are anti-inflammatories or corticosteroids. They receive also, of course, sometimes a what they call a pack, right? A titration pack, meaning they give them a high dosage of medication for one day, and then they slowly decrease the amount until they're down to zero. So that is called a titration rate, which we give to patients, usually again, to patients with rheumatoid arthritis or just arthritis or some other kind of autoimmune disorder. But again, these medications are called glucocorticoids. Okay, they're made also by your body, but we can administer them in different ways. They have, again, a lot of benefits, but they also come with a lot of side effects in the long run. They cause fluid retention. They cause fat retention as well, so people start gaining weight very easily. You can see a lot of the fat start to build up here on the back of the neck. Okay, the face becomes a little bit round. We call it a moon face because of the added tissue. They become very round here and in the neck. And when you see someone like that, you know that they're taking corticosteroids. And if they're taking those kind of medications, we know that they must have some kind of autoimmune disorder. So we can tell a lot by just looking at the person. So again, these medications should not be stopped. From one day to the next. Usually tapered off, little by little until they complete the treatment. So depending on the severity of the problem is how we administer them, either IV or IV infusion or injection, or are going to be orally. So you see the adrenal glands. If you look at the PowerPoint, those adrenal glands. AD stands for next to. So they're next to your kidney. They're actually sitting on top of your kidney. These glands are very important because they produce a lot of the hormones, like cortisol, which is the stress hormone, corticosteroids, mineral corticosteroids, and androgens, and so on. So these glands are very important. They affect the kidneys, but they also affect your entire body. So whenever they release any chemicals, these would be the ones to help you feel better. All right. Of course, antibiotics. We can't go on without speaking about antibiotics. But antibiotics are, of course, medication used to treat infection caused by bacteria. So bacteria can be treated with antibiotics, but not viruses. There's a lot of viral infections, especially right now. There's COVID-19. It is a virus, and it cannot be treated with regular medications. With antibiotics, it's being treated right now with what they call antiviral medications or retrovirus medications. It's a very interesting time that we're living here, trying to fight off this COVID-19. But I believe there's also already some vaccines that are out there. Who will take the vaccine? And, it's up to you if you want to take it. There's many kinds of antibiotics, but there's most of these antibiotics are very what we call broad spectrum. Broad spectrum antibiotics are those that kill a lot of bacteria. Okay. Now in our bodies we have good bacteria that help us stay healthy, and then we have bacteria that do not. They cause problems for us. So when you take an antibiotic, and you're not sure exactly which one you're supposed to be taking, you just take one. Well, that creates problems because not only you're wiping out that bad bacteria, but you're also wiping out your good bacteria, which is why sometimes many people get diarrhea because of the antibiotic. So there's a lot of different kind of types. We should know, especially if the person has any type of allergies. If a person has allergies to medications, then for sure we have to make sure that we don't give them the one they're allergic to. These antibiotics must be given at irregular intervals. Every medication, including antibiotics, has a what we call half-life. So a medication, let's say they give it to you every 8 hours. Take this antibiotic, let's say cephalexin, 500 milligrams, 3 times a day. Why 3 times a day? Because these antibiotics have a half-life, meaning that in about 4 hours, which is half of the 8 hours, they're going to be peaking, right? So they're going to the bloodstream. You take the pill at 8 in the morning. So by noon, by 12 noon, it's already peaking. That means it's already dying off. So that means that by 2, 3 o'clock, you should be taking the next one so that it can start building up more in your bloodstream and maintain a therapeutic effect. That's why we take medications, at such a frequency. Again, it's going to depend on the patient, depending on their body to see how they can tolerate. Some people cannot tolerate, every 8 hours, every 6 hours. So it's going to vary. So it's very important that we take them at the regular intervals. Check the patient's medical records for allergies. Again, very important, especially for penicillin. A lot of people are allergic to penicillin, so we want to make sure that we don't give them anything that is made with penicillin. Also, now the fact that someone is not allergic to a specific medication doesn't mean they're not going to develop an allergy at any point. Sometimes they may develop an allergy for the very first time. So that's why it's important to monitor the patients, right? So it's not just about giving the medication, but observing the patient for the therapeutic effect. How are they doing? They can develop the reaction right away within an hour, 2 hours, or even 5 hours. They can start developing hives, all that body rash. They can start developing the swelling on the lips or in the throat. That would be an emergency, right? So we have to monitor the patient for the therapeutic effects and, of course, report any adverse effects. If the person got diarrhea right away, well, then guess what? We're going to have to make sure that we report it to the doctor, not only the adverse side effect, but also the diarrhea, because it could cause dehydration, especially on older people. So again, it's not just about giving the medicine, but we have to look at the whole picture. Observations to report immediately. Difficulty breathing, again, would be an anaphylactic reaction. Skin rash, which is the hives or itching. Any stomach pain, nausea, diarrhea, or anything to that matter. Any GI side effects. So usually what I do when it's a new medication for a patient, I usually instruct them what the medication is, what it's for, the therapeutic effects that are expected. If it's antibiotic, obviously it's for to relieve an infection, whether it be a local infection, a skin infection, a wound, a respiratory, whatever it is, we want to make sure that it has a good side effect. So I tell the patient.
Mr. Reyes, ¿por qué cuando estamos tomando un antibiotic nos dicen you have to take it for, let's say, a week? Even though we feel better with.
So antibiotics, again, there's so many different kinds. We take a whole course in pharmacology. And it really opens your eyes to everything that we see around here, especially here in the valley, where everybody just runs to cross the border, gets antibiotics, and self-prescribes, self-medicates. And for a while, we had a big problem here. We have we still have it, but it's not as bad as it was before. A problem with resistant strains of bacteria. A lot of bacteria were not responding to penicillin. Just your regular penicillin was not doing the job anymore. Why? Because bacteria developed a resistance to medication because people were taking, oh, I'll take, whatever antibiotic you have. Call my aunt. Hey, do you have antibiotics there at home? Yeah, yeah. Okay, I need them because I got the cold. You know. So again, we have this bad habit of self-medicating, and um, common colds. That it's a virus, right? You can't treat it with antibiotics. That's just it. You have to let it run its course. All right. Which of the following observations should you see in a patient within 24 to 48 hours of starting therapy with an antibiotics? 24 to 48 hours. Should see signs of improvement, no fever, signs of infection. Of course, all of the above. That's the whole purpose of antibiotics, to get rid of the infection. Another type of medication we use a lot are bronchodilators. Broncho refers to the bronchus in your respiratory airways. And of course, dilators means to dilate, right? Bronchodilators, so your airway is going to open up, right? Now, how big is your airway? It's very, very small, okay? Probably about that big. It's not very big. It's supported by muscle around. So that muscle sometimes when it gets irritated, when you're exposed to we call it a pollutant, an allergen, your airway responds by constricting. So it closes. So obviously it's going to make it harder for you to breathe. And it's also going to start many times producing mucus. It's not an infection, okay? It's usually just excess drainage. Okay? Even like when sometimes you smell something or dust or whatever, and your nose starts running. Is that an infection? No, it's just an allergen, right? Your body's sensitive to that particular dust, pollen, aroma, or whatever it is. If you're allergic to it or your body reacts, that means you have a sensitivity, right? A hypersensitivity to that thing or dust or whatever it is. That's all it is. And usually it goes away, right? But some people are just very, very sensitive to a lot of things, like they're always sneezing and coughing and all that. So bronchodilators is a medication that we use to help people obviously breathe better. Okay, people that have asthma or bronchitis, they may be around carrying an inhaler. Okay, and they know sometimes they use it on a regular basis. Sometimes they only use it for emergencies. We call it a rescue inhaler because they have an asthma attack. They pump it and they breathe it in, and the bronchioles relax. Remember, it's your main bronchus, and then it divides into the left and right bronchus, and then those separate into bronchioles, which are very small branches of the whole respiratory system. And then, of course, your alveoli and your lungs. So all your respiratory system with the bronchodilators, your main bronchus and your bronchioles are relieved, not so much the lungs. So make sure that you know what those are. Bronchodilators used to treat respiratory systems. So what do you report? Report, obviously, a person who's having trouble breathing, they're breathing too fast, right? They start to maybe change color, they get cyanotic. If they have history of COPD, like chronic obstructive pulmonary disease, asthma, emphysema, bronchitis, anything like that, if any history of respiratory problems, you should be on the lookout for that. Report increased shortness of breath, right? Increased. Sometimes they get short-winded right away, short of breath. Like they walk from here 10 feet to the restroom and they're short of breath. That's not necessarily, a respiratory problem. Okay, that means they probably have a weak heart. All right, so increased shortness of breath has to be reported. If they're using their rescue inhalers, if they use it more often, that means they may be developing an infection. Okay, so the respiratory system is acting up. Okay, that means they need more inhaler, and that means that has to be reported. Their blood pressure goes up, the heart rate is increased, the heart rate goes up. Whenever the lungs don't get enough oxygen, the heart reacts by pumping faster. Of course, that causes their blood pressure to go up as well. They become anxious or they have trouble sleeping at night. So all these symptoms have to be reported so that we can keep track of these patients and prevent them. The whole point is to prevent them from getting to the point where they need to be hospitalized, especially if if we're working from home or seeing them home or they're in a facility, any kind of facility. Our job is to prevent them from getting to that severe point where they need to be hospitalized because hospitals are very expensive. most of the common bronchodilators that we use are albuterol. Albuterol is a very, very common. We epinephrine. Epinephrine is a chemical that our body produces. Okay, every time we have like a shortness of breath, if you inject epinephrine, it will relieve the symptoms of inflammation, like in an anaphylactic reaction. Epinephrine is usually the rescue, but it's injected instead of inhaled. So those are bronchodilators. Okay, they're very, very well. Now another category that you need to be aware of are antihypertensives. Antihypertensives are used a lot for, obviously, for people that have hypertension. So if you remember a little bit about EKG, a little bit of the anatomy of the heart, okay, we have to pay attention to the blood pressure. Okay, so what is blood pressure? If you recall, blood pressure is the resistance against the heart. Okay, so your heart is pumping, right, and your systemic, right, your arteries that go branch off from here to the arms, to the lower part of the body, to the head, they all constrict and dilate. They constrict and dilate on a need basis. For example, this morning, your body says, wake up, wake up. So your heart rate goes up, your arteries dilate, delivering more blood flow to the brain and to the rest of the body, especially your muscles, they need that blood flow, right? So your heart starts pumping and you start waking up. You're like, no, I'm still asleep. Let me get some coffee. So you drink caffeine, and then that increases your heart rate, right? Increases your heart rate so you get more blood flow. So then now you're like a little bit more awake. You feel a little bit more awake at least. So that that pressure, that resistance against the heart is what we call blood pressure, right? And we look at two numbers. We have your systolic blood pressure, which is the contraction part of the heart, and then we have your diastolic pressure. Diastolic pressure, okay? Your diastolic pressure is when your left ventricle is filling, okay? Your left, or both your ventricles, not just your left, but both ventricles are filling, okay? That is, or they call it the resting phase or diastolic phase, right? But understand that there's still pressure, okay, during the resting phase. So we look at those two numbers. There's always a question. I always get the question: which one is more important, the systolic or diastolic? And I'm like, well, that's not an easy answer. It's more a complicated answer than people think. Your systolic is dominant because the systolic pressure is when your heart contracts. So we want it to be at least over 100 or 90 millimeters of mercury. If your heart is not contracting more than 90 millimeters of mercury, that means you have decreased blood pressure or low blood pressure, or we call it hypotension. So why is low blood pressure bad? Well, it's bad because your tissue, your whole body is not getting enough blood flow, right? They're not getting enough blood flow to the brain, to all the tissue. Now, why do some people have low blood pressure and they're fine? Well, everybody's different. Some people are very athletic. They work out. They do a lot of running. They have very good physical condition. That means that the heart has to do very minimal work, very minimal work to push all the blood. So their heart is in excellent condition, okay? Especially those people that are that run marathons and things like that. The heart may be pumping very, very, is not required. And with one pump, does the work that what most of us take 3 pumps to do. Okay, so that's why they don't, their blood pressure is really low. As long as they don't feel sick, everything's fine. Now, for the rest of us that are not in great physical condition, okay, your heart has to pump, usually at least over 100, but it shouldn't be over 140. Over 140 is considered hypertension or high blood pressure. So now there are parameters. Some patients run high blood pressures more than others. So we always have to make sure that we compare the readings to them, okay? Everybody's different. Okay, we're not gonna have, now if you're a young person, 15, 18-year-old up to, I don't know, let's say 50-year-old person, and your blood pressure is running over 140, then you have a problem. You have a problem. Your blood pressure has to be below 140. Even at 130, they call it pre-hypertension. Pre-hypertension, all right? So make sure that your blood pressure for the patients are always running below 140, 150 is pushing it. Why? Because every time your heart pumps, it puts pressure on the very small arteries that we have, including in the brain, the kidneys, the heart, and so on. So what does it do to the arteries. Well, it causes them to lose their elasticity. So the heart pumps, arteries dilate, pumps, dilates, pumps, dilates. So what happens after many years of having a lot of pressure in your arteries? They stop dilating. Before they were like this. So this constriction, right, we call it atherosclerosis, makes it harder for the heart to pump blood through it. So what does the heart do? Pump even harder and harder, and the arteries do not expand. So this is what develops a chronic hypertension. Okay, there's a diagnosis called malignant hypertension. These people are very difficult to manage their blood pressure. All right, so I hope you got an understanding of what high blood pressure is. But anyhow, make sure you look at the parameters, know the parameters, by memory, and know when a person is, having a hypertensive crisis. So what do we do? What kind of medications? We give medications called beta blockers. This is one type, beta blockers. Beta stands for the letter B, okay? It means that they block B cells, B-type cells in their tissue. Okay, so this is your heart. It has muscle. The muscle is composed of tissue. Okay, the tissue is made up of cells. So this medication will block some of these B-type cells from getting some chemicals like what we call angiotensin. Angiotensin is produced in your adrenal glands. We talked about them earlier. Your adrenal glands produce angiotensin. That means that they make your arteries close. So this medication will keep the cells from getting angiotensin, and that means they're going to stay relaxed. Okay, it's a little bit more complicated than that, but beta blockers is one type. And how do you know someone's taking a beta blocker? If you look at the name of the medication, it's gonna end in LOL, like laugh out loud. LOL, like labetalol, metoprolol, and everything that ends in LOL is usually called a beta blocker. All right, that's one way of knowing it. We have calcium channel blockers. Calcium channel blockers. Again, these medications stop the cells from picking up calcium. Okay, so your muscle requires electrolytes to contract. Okay, like let's specifically talk about the heart. Okay, most of the medications work on the muscle of the heart, right? But they also work on the tissue of the arteries. They make those arteries, relax. Okay, so they block them from picking up calcium, so they don't close. Okay, so we want those arteries to stay open. We want that heart to stay more chill, more relaxed. We don't want it to be overworking, so we give them calcium channel blockers. Another type is angiotensin converting enzymes. So angio means artery. Tensin stands for tension or resistance. So angiotensin converting enzyme inhibitors. It's a very long name. ACE inhibitors are given to patients, again, usually as the beginning stages of high blood pressure. These medications end with LIL. Instead of LOL, it's LIL. Okay, we have lisinopril. It's the most common one. Lisinopril, enalapril. Anything that ends with LIL is considered an angiotensin converting enzyme. So your adrenal glands release angiotensin, and it causes your arteries to constrict. So you don't want that. So what do you give the patient? You want a patient to have relaxed arteries to reduce the resistance, right? Or reduce the high blood pressure. So ACE inhibitors. Your arteries convert angiotensin 1 into angiotensin 2. Okay, so some medications are used at the second level. They try to prevent angiotensin 2 from being picked up. But that's another category of antihypertensives. And there's a lot of them. Probably not enough time to go over all of them here. And that's not the purpose of this course. But you have to make sure that you know at least what kind of medication they're taking, what to look out for. Like in beta blockers, if the person is taking a beta blocker, the main thing that we need to be concerned about is the heart rate. Why the heart rate? Because beta blockers keep your heart from contracting. Remember, they act on the muscle tissue and they make it less responsive. Okay, and so your heart will contract slower, not the same strength but slower. All right. let's say the person has a heart rate of 100, you give them a beta blocker, and if you give them enough, your heart rate will come down gradually. Okay, so people that have a lot of anxiety, sometimes they prescribe them a beta blocker, not because they have hypertension, but because they want that heart to slow down. Remember, after working too much, that heart is going to get enlarged, right? I think we discussed that in EKG with left ventricular hypertrophy, right? Your heart gets large because of too much work over a very long time. So observe the patient and report immediately if the pressure is higher than their normal. Okay, again, they're normal, or even if it's lower than the parameters, especially if the patient takes the symptoms of low blood pressure, such as they get dizzy, they're weak, they're tired. Okay, what do? Well, right away we need to elevate the extremities. Okay, report it to the nurse. We have to maintain an open airway, make sure they don't stop breathing. If they get to the point where they get short of breath, we can add oxygen. Okay, at this point, if in a hospital, we would give medication to bring that blood pressure back up, okay, or to counteract the effects of the medication. So dizziness or fatigue could be signs of not enough blood flow to the body, okay. Nitroglycerin, it's not so much an antihypertensive. These are called anti-anginal medication. Angina is chest pain. So if a person that experiences chest pain, is usually because there's decreased blood flow to the muscle tissue, right? If the arteries in the heart are occluded, and there's decreased blood flow to that specific part of the heart, then the person or the tissue sends off a signal of pain, okay? And the person says, oh my God, it hurts right here. I have chest pain. It's called angina, right? How do we relieve that? We relieve it with a medication called nitroglycerin. Nitroglycerin, again, very strong medication. It's given in several ways, but most commonly sublingual, right under the tongue. Very small pills. They come in a very small little jar. Okay, they have to be protected from light. They have to store it in a cool place, away from light. They're light sensitive. And if a person complains of chest pain, okay, usually you give them one, put it under the tongue, okay, and wait for the symptoms to resolve. What does nitroglycerin do? What does it do? Well, it helps the arteries in the heart dilate. Okay, again, under the tongue, absorb very quickly. The arteries in the heart are going to receive that signal, and not just the arteries in your heart, but your entire body, they will dilate. Okay, so it increases the blood flow to the heart. Yes, that's what you want, but it also decreases your systemic blood pressure, like the blood pressure to all of it. Okay, so you can have too low blood pressure, but you can't have too high. That's why we have parameters. So we have to make sure that that the medication has a therapeutic effect. We want the chest pain to be relieved, but we don't want them for the blood pressure to drop, because then we're going to have another problem, right? So this medication, again, used to treat angina pectoris or chest pain, again, caused by the lack of blood flow to the heart tissue. We only give this medication up to 3 times, okay, every 5 minutes, usually. Every 5 minutes, up to 3 times. So if you know someone in a family that has this medication, you can only take one, wait at least 5 minutes, and if the symptoms are not resolved, you give them another one, okay? At this point, you will probably want to call 911 just in case, all right? And wait another 5 minutes. If the symptoms are not resolved, right, at this time, you're thinking CPR. That's the only thing you can do, right? If the person does have a heart attack, okay, the person, you're ready there to provide basic life support, all right? And hopefully EMS has already been informed and so on. But if, some people have this problem all the time, okay? They have this problem all the time. The, the chest pain is chronic chest pain, okay? This is when people have already had a bypass surgery, maybe two or 3 times or once, but they can't have any more. This chest pain becomes very chronic, okay? It also happens with a left ventricular hypertrophy, like heart failure. They get this chest pain a lot too because their heart is just too weak. So this medication can be given sublingual, buccal, means in the cheek, okay? A pill, something to swallow it, that's not very common. Transdermal, meaning a patch. Sometimes we use those for more to improve circulation to a certain part, like usually the legs. We put like, it's a cream, it goes in a little paper, and we stick it on the leg, and it dilates the arteries of the leg to improve blood flow there. IV, we can also give nitroglycerin IV in case of emergencies. Observations to report, obviously, if you take it more frequently, the person has a history of chest pain or heart disease, and they seem to be using it more frequently. Maybe they haven't used it in the last 3 months, and now like every other week they're having to use it. That's a red flag. That means that something is going on in the heart. Maybe more occlusion, maybe developing a heart attack, and so on. If the patient tells you that the medication does not relieve the symptoms, they may be actually having a heart attack. The blood pressure again goes too low, the pulse rate is high. Okay, usually when the blood pressure drops, the heart rate goes faster. The heart tries to compensate, right, for the low blood pressure. They try to beat faster. Other medications that we use are called cardiotonics. Cardiotonics are medications that slow the heart rate, kind of like the beta blockers, but these actually helps the heart contract harder, okay? Because people have heart failure, which is a very common problem, okay? They get prescribed a cardiotonic. What it means is that it's kind of like a boost for their ventricles so they can contract harder, but they also slow it down. It's like slow down, but contract hard, okay? This is the cardiotonic. Frequently used to treat atrial fibrillation, which is one of the conditions we discuss in EKG, right? Remember, atrial fibrillation is when the right or the atrium, which are on top of your heart, right? The upper chambers, they tend to fibrillate instead of contracting. They quiver, okay? That can cause blood clots and so on. So this digoxin could be used to treat this. So digoxin is the most common one that you're going to see. It's a cardiotonic. And one of the main things that we need to look for is the heart rate. Again, has to be over 60 because it will slow it down. But also we have to look out for signs of toxicity. Digoxin is derived from a plant. It comes from a plant, and if you take too much of it, it's going to make you see everything yellow. Everything's going to look yellow, like you're looking through a yellow window, or some, you see sometimes you have glasses that have a yellow screen. You put them on, and everything looks kind of yellow, right? So this is what digitalis toxicity is. This is what happened to a famous artist. His name is Van Gogh. They believe that he was taking, it's called something fox, the fox plant or something like that. He used to see yellow or see yellow halos around lights, around everything. So this, they believe that this is what happened. He took too much digitalis and he died from that. Report apical pulse, which is the apical pulse right here, less than 60 beats per minute. Too much digitalis. Nausea, vomiting, any visual disturbances. So if they're seeing things like yellow lights or halos. If you look at a light, now we have other kind of lights, but if you see like a halo around a light, that means you have too much digitalis in the body. Very weak or fatigue, that means that the heart rate is too slow, or bradycardic. Anticoagulants, again, very, very common medication that you're going to see, also known as blood thinners. People take it again for atrial fibrillation. Is one of the most common reasons, right? Because when they have atrial fib, they tend to form little blood clots. And to prevent that, they give them anticoagulants. Or maybe they develop a blood clot, deep venous thrombosis in their legs, or they have a tendency to develop blood clots in their, in the bloodstream. We give them an anticoagulant, these blood thinners. Warfarin is an old anticoagulant, but still in use. Heparin is another anticoagulant. Now there's a bunch of new ones. Eliquis is one that comes to mind. It's one of the newer ones. The difference being that warfarin has to be monitored on a regular basis. Okay, we have to do PT-INR for warfarin, and nowadays we don't have to do that for Eliquis. We can do it maybe once a month, or if we see symptoms of the patient maybe having prolonged bleeding, right? If they get a little cut and they take a long time, which they will anyways. But if it's too much, If they start urinating blood, we call it hematuria. If they start pooping blood, we call it melena. Or they start to vomit blood, okay, we call it hematoemesis. Those kinds of things are signs of what we call heparin toxicity or warfarin toxicity, or some kind of blood thinner that is prolonging the bleeding time. They're also used for people that are going to surgery or after surgery, rather. After surgery, if they have a high risk of developing blood clots in their legs, they have poor circulation, the doctor will prescribe usually Lovenox. Lovenox is a brand name, enoxaparin, which is a type of heparin, a weak type of heparin, is injected subcutaneously. Okay, so we grab a piece of fat and we inject it in there, and that will increase their clotting time, right? So they don't form clots in their legs. Very serious complication. A person that has history of stroke, they may be given at least an aspirin, or if not, something like Eliquis or some other kind of anticoagulant, or dysrhythmias like atrial fibrillation. So anticoagulants, again, the main things that we need to look out for, of course, are blood in the urine, blood in the stool, vomiting blood, or if they fall and hit themselves in the head, you have to report that. Obviously, they have to go to the emergency room for a CAT scan to make sure that they're not bleeding in the head. Or if they fall somewhere else outside, if they have blunt trauma, they hit themselves any part of the body, that would also require them to have some kind of CAT scan to make sure to rule out any internal bleeding. Diuretics, also very common. Diuretics are medications that make the kidneys filter more blood, okay? So the point or the purpose of your kidneys is to balance the fluid in your body. That is the main point, okay? So if you drink a glass of water, okay, your kidneys are gonna say, well, wait a minute, there's too much, the blood is too watered down, let's get rid of some of that. So it'll form urine, right? It'll clean it out, and then you go to the bladder, and then you go to the restroom. Okay, this is what the kidneys do, okay, among other things. They also regulate blood pressure, but that's another topic. So your kidneys are going to filter more blood, produce more urine, and go to the restroom. So why do we want to give someone a pill like that? Well, believe it or not, there's some people, silly people out there that are taking it to lose weight. But that's kind of dumb because you're going to replace it when you drink water again. But for people that do need it, we give it to reduce blood pressure. It's one of the first line of medications used to treat hypertension or high blood pressure. Okay, why? Because people that have high blood pressure tend to have a higher level of volumes circulating in the bloodstream. We should have about 5 liters of blood in our bloodstream going at all time on average, right? On average. If you drink more water, right, or people drink alcohol, you know, we drink more than one, that adds volume to your circulation. So what does that mean? It increases the workload on the heart. So that increases your blood pressure. So we're going to give you a little pill. You take it, it's going to make you urinate more. So you get rid of the excess fluid, okay? Reducing volume, reducing the workload on the heart. Okay, very, very simple, very straightforward. These medications tend to have an ending with IDE. IDE. If you have a furosemide, it's a water pill. Chlorothiazide, it's a water pill. Hydrochlorothiazide. Okay, so there's a lot of medications that end in IDE, and these are called diuretics. Okay, mostly, again, used to treat hypertension. Sometimes for other reasons like removing potassium when a person has high potassium levels. We have to monitor their intake and output. Congestive heart failure, I would say, is the most common reason why people take water pills. Congestive heart failure, and sometimes they have more than one. They have more than one diuretic because their heart is so weak that it's not strong enough to pump the blood to the kidneys so the kidneys can filter and get rid of the excess. Okay, so sometimes they require more than one diuretic medications. We have furosemide, hydrochlorothiazide, anything that ends with IDE is a diuretic. Now, what do we have to look out for people that are on diuretics? Well, number one, dehydration, right? If they're taking too much medication, they're urinating a lot, you look at them, their mouth's completely dry, their eyes are sunken in, their urine is really strong. That means they're over dehydrated, right? Their pulse is going to be weak, irregular. They may complain of muscle pains. Why? Because when you take a diuretic, you're going to eliminate potassium. Okay, the kidneys will eliminate potassium when they're removing the excess fluid, and that depletes your muscles of potassium, especially of your heart. Your heart is a muscle, and if it doesn't have enough potassium, because it works mainly with potassium, calcium, then you might have dysrhythmias, and that could be a serious problem. We have to, feel the fluttering or chest pains or things like that. So if a person is on diuretics, this could be a serious complication. Indication that diuretic is not working. Obviously, if it's not working, the swelling does not go away, the edema, the excess fluid in their lower extremities does not go away. So they build up this excess fluid in their body, right? And it starts to go into the lungs, and it gets really complicated. The blood pressure goes up, the urine is decreased. It's very obvious when a person's diuretic is not working. Sometimes we have to weigh them. Sometimes we ask our assistants to go ahead and weigh them. Sometimes on a daily basis when they're in the hospital. Sometimes every week or every other day when they're in their home or in the nursing home. We weigh them at least every other day to make sure that the diuretic is doing its job. If not, the patient will exacerbate, right? Their symptoms will get worse and they will end up in the hospital. So it's a very, I would say, fairly easy problem to manage, but we have to stay on top of it. Congestive heart failure, one of the most common diagnoses out there in the older people, older populations. And I think it's usually undermanaged. It's not, or incorrectly managed by the caregivers because they don't know. Many times it's a lack of knowledge. And so we have to go in there and teach and instruct and teach and instruct until they get a hang of managing the problem and preventing these patients from going to the hospital. Antispasmodics are not very common, but they are out there, more so for overactive bladder. There's a lot of older folks that suffer from overactive bladder, so they have to go to the restroom too often. Many times it could be an infection, but a lot of times they just have an overactive bladder. It happens with age. The bladder fills to, or doesn't fill, okay, and it wants to empty itself. Okay, they drink a glass of water, and usually before you would drink a gallon, you go to the restroom. Now you drink a glass of water, you got to go to the restroom. That is called the overactive bladder. Not too common. That, some complications that can occur, of course, are difficulty urinating. Maybe the bladder will not empty itself anymore. They have spasms, decreased urge incontinence. Like you got to go, you have to go right now. If you don't go, you're not going to make it to the restroom. That's a problem. Medication used to treat diarrhea. Well, we try not to give antidiarrheals to patients because many times it comes out worse than the cure is worse than the problem. So, but they're out there. You can buy them over the counter as well. Loperamide or Imodium is an antidiarrheal. Some people take it, but again, I usually encourage people just let the diarrhea run its course as long as you're hydrated. Okay, but if it becomes a problem, like you always have it, then you might want to have see a doctor or take at least one of these once a day. I have a resident. She has a condition called irritable bowel syndrome. That means that their intestines are very hyperactive. She's always having this cramping and this gassy and bloating, and it's very problematic. And this is chronic. She's had it all her life. All right. So once in a while, when she gets like that, I usually instruct her, encourage her to ask me for loperamide, right, for an antidiarrheal to slow down, right. Now there's medications like another one like Lomotil, which is the same thing, but some of these medications also have side effects which can affect the heart. So we don't want to give too much of loperamide or too much of Lomotil because we can have some other complications. Laxatives, stool softeners, or other types of medications to manage constipation. Fiber supplements, there's a whole bunch of other ones. Again, some work for some people, some work for others. But we always try to encourage people to take something to help them have a normal bowel movement as possible. It's very important. Elimination is part of your basic needs. Okay, so if you're not eliminating on a regular basis, then you can have other problems develop. diverticulitis, or even cancers in your colon and so on. So it's important to eliminate things on a regular basis. How are laxatives used? Well, they're used to relieve constipation. Hyperthyroidism. Hyperthyroidism. Hyper's high, thyroid relates to your thyroid glands. Okay, thyroid is a very important gland. It produces a lot of hormones and chemicals for our body, for growth, to regulate your metabolism and so on. So it's very important that your thyroid work properly. Now, as we get older, the thyroid does slow down. It doesn't produce as much thyroid stimulating hormone as it used to. So they have to replace a little bit of that. Okay. Now, when a person is taking thyroid medication, we have to make sure that they don't overdo it, right? They don't take too much of it because their metabolism goes too fast. Now they start losing weight. Okay, they become very irritable. They don't like cold weather. They sleep a lot, or their heart rate goes up. Uh, it's called hypothyroidism. Some people have natural hyperthyroidism, which is called Graves' disease, and you can see people out
Sir, so entonces los que tienen hyperthyroidism tienen high blood pressure y problemas de la tiroides.
Not necessarily. Hold on. I'm trying to pause it. Oh, here it is. We're almost done here. Okay. So again, hypothyroidism, hyperthyroidism have to do with your thyroid gland, and this book doesn't discuss it, but we have other glands next to your thyroid gland, which are parathyroid glands that also produce other hormones. So report any signs, right, that you see in a person who's taking thyroid medication. Either they start to lose weight, cold intolerance, they get irritable, the heart rate goes up. What I mean up means over 100, right? Over 100 beats per minute. Another very common medication that we give is insulin. Insulin is a hormone. Our body produces insulin, and it helps us to utilize the glucose that we eat, right? So I ate oatmeal this morning. Oatmeal is a fiber, it's a carbohydrate, okay? With milk, carbohydrate, right? Nuts and cinnamon and honey, whatever. So our body right away releases insulin. Your pancreas, right, in a small part of the pancreas, they call it the islet of Langerhans, is a very small part of your pancreas that actually produces insulin. So what happens after your body has overused insulin, up to 40, 50 years old? Well, there's decreased insulin in your body. So what does that mean? It means that you're going to start to develop diabetes, right? So if you see little kids nowadays and you observe their skin, okay, I think I probably mentioned it before. You look at their skin and the skin folds, right? Like the knuckles, here, in the neck, very, very obvious in the neck, and the waistline. Wherever we have a skin folds, you'll see dark pigmentations. Dark pigmentations. We call it, it's called linea nigra albicans, right? Means black lines. Okay, black lines that are formed in the folds of the skin. Why? These black folds are because of insulin resistance, right? We have a diabetes problem here, especially here in the valley, but nationwide with child obesity. And this is one thing that I don't like to see, because I was an obese kid, right? And when I see other obese kids, I'm like, it bothers me, because I think it's a parent problem, right? A parenting problem. Kids do not eat what we don't feed them, or we don't allow them to feed themselves. So if they're kids, we should be telling them what to eat and how to eat, teaching them how to eat, right, properly. So when I see kids, and I look at the diet that we have nowadays, we all go and buy pizza and everything fast food, and it's okay to go do it, but don't do it on a regular basis. Like, go buy your kids every day fast food. It's not healthy for them in the long run. So we see kids with insulin resistance, all right? And why are kids so big? If you notice, why are these darn kids so big? Because of insulin, right? So we see these little kids that are like, hey, I have a family member, just call him family member, a boy, he's 12 years old, and he's huge. He looks like a 20-year-old man. Why? Because he's always been very obese, and he grew like tomorrow. Remember we talked about little babies when they're born, and you see the babies, they're coming out like 8 pounds, like that big, okay, because of insulin, right? Because mommy decided to eat a lot, and the baby grew a lot, produced insulin, the baby just grew a lot, okay, and the little testicles look very dark, very dark. It means they have a lot of insulin, right? Because they have a lot of wrinkles there. Remember, the babies, they're nice and stretched, right? They're all fluffy. They have no wrinkles except in the scrotum. So we see the scrotum and they're all dark because mom probably ate too much. So all that insulin went to the baby and it just made a big baby. So we have insulin. Okay, again, it's a hormone. It's a growth hormone. Bodybuilders use it still. Okay, if they want to get bigger and bigger, they take insulin injections, right? But they eat a lot. They eat a lot, they take insulin, and they get really big. So insulin, there's different kinds of insulins. We have short-term, what you call fast-acting insulins. We have intermediate, which are like not too fast, not too slow. And then we have what we call them lente or lentas, very slow-acting insulins. So what is short-acting or fast? It means that that medication, once injected, is going to work within 30 minutes. Boom, it's gone. Okay, those are very fast-acting. Actually, that's another category. But anyways, so we give those insulins when the person is already going to start eating. Okay, you don't want to give that insulin, that short-acting fast insulin right now, and then he's going to eat 2 hours later. That's not going to work. That's going to drop the blood sugar, right? We give intermediate insulins for those people that have trouble managing their blood sugars, right? So we inject it, and it's going to be absorbed, right? It's subcutaneous. Remember, in the fat of the fat part of the skin, it's going to be absorbed slowly. The medication is absorbed, over a long period of time. So intermediate acting insulin usually will last about 6 to 12 hours in the body. Okay, so it slowly, absorbs it, and it's going to help that person, maintain a higher level of insulin because the body doesn't produce it anymore. So that when they eat breakfast and they eat in between and they eat lunch, they have it. So these insulins are usually prescribed twice a day. Remember we talked about half-life, right? Goes up, peaks, and it starts going down, and here's the next dose. Boom, goes up and down. I see. So we have to make sure that we administer it at the right times. Usually scheduled around meal times. Okay. So again, fast acting and then intermediate, and then you have long lasting or very slow acting insulins, which can last in the body up to 24 hours. And these are very common. Okay. So we have Lantus insulin, we have Levemir insulin, and there's just a whole bunch of them that act very slowly and they're very effective. However, everything comes down to the patient's eating habits. All right. So I have a patient, he's very, what we call brittle diabetics, meaning they can have their blood sugars at 300 milligrams per deciliter, and then in 2 hours they're down to 180. They drop very quickly. Okay, so I always have to keep an eye on this guy. Is he eating? Did he eat? How much did he eat? I have to make the decision where I'm going to give him the insulin, the fast acting, or not. Right? If it's like 300 and some, I just give them the insulin. No, now they're very small doses. The fast acting insulins are prescribed in very small doses, like 3 units, 4 units, 5 units. Very. The most is like 10 units, and that's when they're already at 400. Okay, but sometimes the doctor will prescribe we call a sliding scale, right? A sliding scale means that if the blood sugar is between 150 and 200, give them 2 units. 201 to 250, 3 units, and so on. Okay, that's called the sliding scale, and sometimes we follow that. Okay, for some patients. And then you have along with that, they might also have a long-lasting insulin, like the Lantus or the Levemir. It's very common here in the Valley. Almost every other person takes insulin because they have diabetes. So again, those are the 3 kinds of insulin. There's pills, of course, medications, oral tablets that are given to patients with diabetes, and they helps them produce more insulin, helps them to better utilize the sugars that they're eating and so on. Metformin is one of the most common ones, or it's called, metformin is the generic name, super common. Metformin is also given for other reasons, including weight loss, or it's even used to treat uterine cysts, right? For women that get cysts in the uterus, glucophage metformin is also used for that purpose. So what are the most common side effects or that you need to look out for? Of course, low blood sugar. So the patient's blood sugar was at, say, 200, and you give them insulin, and then it drops, and then the patient forgot to eat or doesn't eat, then the blood sugar continues to drop. You know, it can get low enough where the person starts to develop symptoms of low blood sugar or hypoglycemia. Hypoglycemia is a serious complication, right, or serious side effect of the medication. We don't want hypoglycemia. We just want, you know, blood sugars to stay within normal. But what do? Well, you look out for increased thirst. I'm sorry, for hypoglycemia, they get weak, they feel drowsy, they get sleepy, and most commonly, they will get diaphoretic. Remember, diaphoresis means sweat. Cold, sweat, they feel sticky. Okay, with this patient I'm talking to you about, I had this problem with him several times already. Okay, so I have to really keep an eye on him, on his blood sugars. So it can come to the point where it can become unconscious. Okay, they're responsive. You can talk to them, but you know, they're getting very sleepy. What is the problem? Is that their sugars can come so low that the heart will stop. If there's not enough sugar in your body, your brain shuts down, and then your heart will stop, and you go into cardiac arrest. So we don't want that. So we have to make sure that we maintain those blood sugars at a, you know, at a decent level. So we have to make that decision, that judgment. Again, it's not just about giving the insulin; it's about knowing what to do, what to look out for when you administer a medication such as insulin. Now, some people get hyperglycemic, means high blood sugars. There's a lot of people that that lose weight without even trying. If you're losing weight without trying, you probably have diabetes or cancer. Diabetes, when your body doesn't make enough insulin, it's going to make you, okay, it's going to make you use some other kind of source of energy. Because your body cannot use sugar because there's no insulin. Well, where's it going to get the energy from? From fat, right? So you're losing all this fat, and you're like, oh my God, I'm losing weight, I'm looking good. But in reality, your body is using up fat as energy, which is not a good thing because it produces ketones in your body. Ketones are bad for your brain. So after a long time, your body has too many ketones, then you can go into a coma, call it diabetic coma. All right, which is actually better than dying than hypoglycemia. However, you can have some brain injury. You can have some brain damage because of the ketosis. Remember, or you cannot have too much ketones. It's acidic. Your body cannot survive in an acidic environment. So again, insulin is a great medication. Very effective, and it's not that critical. It's not like, wow, like if I give it to you, you're gonna die. It's not that critical as long as the blood sugars are within normal. Okay. Again, that a lot of these oral medications for diabetes also, we just have to keep an eye on the kidney function with the lab work, because taking too much of these oral hypoglycemics can affect your kidney function, especially glucophage or metformin. It's been known to cause kidney damage. So it's important that we keep an eye on it. All right, well, that wraps up pretty much chapter 15, common medications and categories. I went a little long, but I think I covered it just in time. If you have any more questions, please ask away. I will answer them here or in class. So